In this video, we will discuss disorders of the eyelashes. Eyelashes form an important protective barrier for the ocular surface. Disorders of the eyelashes may cause chronic irritation, epithelial erosions, corneal ulceration, and panus formation. Early recognition and appropriate treatment are essential. The eyelash follicles lie at the anterior lid margin with their roots resting against the anterior surface of the tarsal plate. The cilia pass between orbicularis oculi and rheolin muscle. Normally, the lashes curve away from the globe, preventing corneal contact. Misdirected lashes are lashes that are abnormally directed towards the ocular surface. Persistent contact causes irritation, watering, photophobia, and corneal damage. The causes of misdirected lashes are trichiasis, marginal entropion, dystichiasis, and epiblepharon. Trichiasis refers to misdirection of lashes arising from anatomically normal follicles. The lid margin itself remains normally positioned, distinguishing it from entropion. This is the most common cause of misdirected lashes. Chronic lid margin inflammation is the most common cause of trichiasis. Trauma and surgical procedures can alter follicle orientation, leading to lash misdirection. Marginal entropion causes inward rotation of the lid margin, leading to misdirected lashes. Here, the posterior lamella is shortened. It is increasingly recognized as a common cause, especially in elderly patients. Typically, numerous aligned lashes are involved. Dystichiasis is characterized by an extra row of lashes arising from the meibomian gland orifices. These lashes are often fine and directed posteriorly towards the globe. They may be congenital or acquired. Congenital dystichiasis results from failure of meibomian glands to develop normally. It is an autosomal dominant inheritance. Here, a second row of lashes emerge at or slightly behind the meibomian gland orifices. They are often asymptomatic until the age of about 5 years. Acquired dystichiasis occurs due to metaplasia of meibomian glands following chronic conjunctival scarring disorders such as chemical injury, Stevens-Johnson syndrome, or ocular cicatricial pemphigoid. The cilia tend to be non-pigmented and stunted, and these patients are usually symptomatic. Epiblepharon occurs due to a redundant skin and muscle fold that pushes the lashes against the globe. It is commonly seen in children and often resolves spontaneously with growth. Now, let's discuss the treatment options available for misdirected lashes. A temporary treatment option is epilation with forceps, which is a simple and quick procedure, but recurrence is almost inevitable within a few weeks. Definitive non-surgical treatment options are electrolysis, laser ablation, and cryotherapy. Electrolysis destroys the hair follicle using electric current but may require multiple sessions. Here, a fine wire is passed down the hair follicle to ablate the lash. It is useful for limited number of lashes. Scarring can be a complication. Laser ablation targets the follicle precisely. It is done with a spot size of 50 microns of 0.1 to 0.2 second duration and 800 to 1000 milliwatt power. The base of the lash is targeted and it is useful for limited number of lashes. Cryotherapy is applied just inferior to the lash base. It is effective for multiple misdirected lashes but carries a higher risk of local complications such as lid depigmentation, madarosis, and lid necrosis, and is less commonly used today. Surgery is indicated in extensive or recurrent disease. Procedures aim to redirect lashes or eliminate abnormal follicles while preserving lid function. The common procedures are tarsal fracture surgery, full thickness eyelid pentagon resection for a focal group of aberrant lashes, lid splitting procedures with follicle excision, and anterior lamellar rotation. Eyelash ptosis is a condition characterized by downward sagging of upper lid lashes. It may be idiopathic or associated with conditions such as floppy eyelid syndrome, dermatochalasis with anterior lamellar slip, long-standing facial palsy, etc. Trichomegaly refers to excessive eyelash growth. It may be in terms of increased length, thickness, or pigmentation, and may be congenital, drug-induced, or systemic. The most common cause of trichomegaly in ophthalmic practice is the use of topical prostaglandin analogues for glaucoma. Other causes are phenytoin, cyclosporin, malnutrition, porphyria, hypothyroidism, and congenital syndromes. Madarosis refers to loss of eyelashes. It may be partial or complete, unilateral or bilateral. It may result from inflammatory, neoplastic or systemic causes. The causes of madarosis are chronic lid margin disease, infiltrating lid tumors, burns, radiotherapy or cryotherapy, alopecia, psoriasis, systemic lupus erythematosus, leprosy, hypothyroidism, and trichotillomania. Poliosis is localized whitening of eyelashes or eyebrows and may indicate underlying ocular inflammation or systemic disease. Poliosis is associated with both inflammatory eye diseases and systemic conditions, particularly autoimmune and neurocutaneous syndromes. The causes are chronic anterior blepharitis, sympathetic ophthalmia, idiopathic uveitis, Ward-Koyanagi-Harada syndrome, Waardenburg syndrome, vitiligo, Marfan syndrome, and tuberous sclerosis. For exams, remember the origin of lashes in trichiasis versus dystrichiasis. Trichiasis arises from normal follicles, dystrichiasis arises from meibomian glands. And always consider systemic associations in poliosis and madarosis. Recurrent trichiasis needs definitive treatment.